Hello, Las Vegas. Welcome to Fertility Thursdays with NFI. I am Dr. Cindy Duke, Medical Director and Physician here at the Nevada Fertility Institute. I'm coming to you this week during a very somber time for us here in Las Vegas. And before getting started, I just wanted to take a moment of silence to acknowledge those who were injured, those who unfortunately succumbed to the unfortunate events that occurred earlier this week. Please join me. Okay, so as I was saying, this week has been a very trying week for most of us here in the city. Very unfortunate and unexpected events. It certainly was the lead up to this week's topic of conversation, which is the topic of oncofertility, another somber topic. Today, my hope is to cover oncofertility, to cover what it means to help educate and raise awareness amongst you, the viewership, what that means, how we serve to help patients who are faced with a cancer diagnosis, and to help spread the word that these services even exist. So oncofertility, as the name suggests, is a combination of two words. So it's onco, meaning something related to cancer or malignancy, and fertility. Specifically, it has to do with patients for whom their treatment for their cancer therapy most likely would lead to untoward damage or complete loss of their future fertility potential. For example, in female patients, oncofertility really has to do with what effect will a cancer treatment, whether the treatment be surgery, chemotherapy, radiation therapy, how might that affect a woman's ovaries, and most specifically, how might it affect her eggs? And then in terms of male patients, oncofertility refers similarly to how might the therapy that's proposed, whether it be surgery, chemotherapy, or radiation, affect his future chance of making new sperm. And so, for obvious reasons, in terms of women, we've talked about this many times, the number of eggs that she has at any given point in her life is what she has. So she will not be making new eggs. And thus, if she's exposed to regimens, therapies that can cause egg damage, it's a loss of those eggs. There's no potential salvaging of the eggs if they're damaged. And so that's how the term oncofertility came up. What I'm going to go into now, what are the options for a man or woman, depending on what sort of diagnosis they're facing. And so for some patients, they're facing a diagnosis in terms of women of cancer that actually involves their reproductive organs. For others, it may be a cancer as distant away as the brain. It may be some other form of cancer somewhere distant from the ovaries. But if treatment involves chemotherapy, for example, chemotherapy is typically delivered intravenously so that the therapy circulates throughout the entire body, and thus it will also be delivered to the ovaries, even if the cancer isn't necessarily located in the ovary. In terms of radiation, radiation treatments range from very localized treatment, meaning just one point area of the body is radiated, versus for some patients, they have to undergo whole body irradiation. And that would include patients for whom maybe they're planning a bone marrow transplant, etc. They also have to undergo whole body radiation. For some patients, it's surgery. And like I said, in the context of, say, a patient whose cancer involves her reproductive organs, that surgery may well include a plan for removal of her ovaries. And so with all that taken into account and consideration, there are now options. Technology has advanced to such a point that we can offer options for salvaging or saving the options for future fertility, meaning giving a patient the opportunity, the chance to have children who are biologically theirs in the future following their treatment for their cancer. So treatment options range from freezing eggs. Egg freezing is a standard of care, and it is a standard of care that's available for women of reproductive age who are facing a cancer diagnosis, facing a treatment protocol that includes regimens that are known to be damaging to the ovaries and the eggs, or someone who's facing a surgical plan that may include removal of the ovaries. Egg freezing is a standard of care that's available to all women, whether they be married, with a partner, or single. Embryo freezing, which is considered the gold standard for fertility preservation, is also an option. However, an embryo, as you might recall, is actually a fertilized egg, which means it requires sperm. And so embryo freezing, while it's the gold standard of care for freezing and future fertility preservation, it isn't something that's really an option for every patient. That is, if the patient is young and doesn't have a partner or is in her teen years, certainly that's not something they're really thinking about, and certainly hasn't had thoughts on future paternity for their children. Or if you're a single young woman, or even if you're married but wanted to maintain your options for future paternity of your children, then embryo freezing would not be an option for such a patient. In terms of what are the other options? So for women, let's say you have been diagnosed with a cancer, you have been prescribed a certain treatment protocol, but the doctor wants you to start treatment right away. What are your chances of successfully completing a fertility preservation regimen prior to going into your treatment for the cancer? Well, the short answer is we work very closely with your cancer doctor, and there are many times options that we can offer, which range from maybe giving you some medications that have been shown to be somewhat protective to the ovaries and the eggs, to at least give you that chance of not only resuming menses or menstrual cycle following your treatment, but of hopefully giving you a better chance of your eggs surviving the therapy, versus if we have at least 10 days or so, we can go ahead and prepare to harvest eggs. The process for egg retrieval or egg harvest, and thus freezing eggs or going on to make embryos, they're near identical in terms of what the woman or the young woman would experience. She is treated with medications regularly. We then put her to sleep and we harvest eggs. For a lot of people, when they hear about these options, the first and the, of course, logical next question is, but that costs a lot of money, right? And the truth is, it's very affordable, and there are a number of ways that we've worked to make it affordable. Here at Nevada Fertility Institute, one of the things that we did was we partnered with a number of charitable organizations, one of them being Live Strong Foundation. And we're able, for the vast majority of our patients, if not all really, who are seeking oncofertility services, whether it be egg freezing or embryo freezing, we're able to get them their medications for that cycle at no cost. So that's the first way we help save them on cost. And the medications have a significant cost typically, so we're able to save them on that. We've also partnered with some of the pharmaceutical companies and some of the local pharmacies and national pharmacies to further offer programs whereby the patient is able to get their medications in a timely fashion. You can get them as quickly as within 24 hours of completing the application. I actually haven't come across anyone who's denied Livestrong since we've partnered with them, and we're able to get you your medication so that we can start as soon as possible. In terms of the fees for service, here at Nevada Fertility Institute, I have actually waived all fees for me, the physician. So I do these services, I perform them as an act of love. For me, it's really important that patients have this option. And so we waive the physician fees. So really, the only costs that are then transferred or asked of the patient are to cover some of the laboratory fees, which are very nominal and very affordable. So I encourage everyone who's listening today, whether you first personally faced a cancer diagnosis or not, to keep this in mind and to please help me spread the word. Help me encourage patients so that they know about this. Maybe it's someone that you work with, a coworker, perhaps it's a friend or a family member who themselves or their child is facing a cancer diagnosis. Perhaps it's someone at your place of worship. We encourage you, and we really are working on spreading the word. And what we're spreading the word on is that fertility preservation is an option, that for patients who are facing a cancer diagnosis, even women, including women who do not have a partner, or young women, teenagers, adolescents, pubescent girls, there are ways to preserve their fertility and thus ensure or improve their chances of being biological parents once they've recovered from their treatments. The other thing to know is that for male patients, we also offer services. I'm very pleased to say that we have a full-time andrology laboratory, i.e. we have a full-time laboratory capable of freezing sperm and storing sperm long-term here in Las Vegas. Previously, many patients, depending on when they needed to have sperm frozen, would have to go out of state to do that. We're here and we're able to do it on a full-time basis. Compared to freezing eggs or embryos for women, the process for sperm freeze is a lot shorter. We're able to get a consultation that morning, and by that afternoon, freeze sperm for our patients. Again, we just need to be contacted. For many patients, we do need a referral from their oncologist or one of their physicians, but you can come in for a consultation without that. But if your insurance provides coverage for Oncofertility, and some insurances do, then a referral is most likely needed. If you call us up, we can help you figure that out as well. Otherwise, in terms of Oncofertility, some questions that we get are things like, well, how long can sperm, eggs, or embryos stay frozen for? And the answer to that is in perpetuity. That is, in theory, they can stay frozen forever. The question that we also get asked oftentimes is, what do I do about it if I can't find someone, like in terms of a woman or a man? What if I decide to use my frozen eggs or my frozen sperm, but I do not have a partner? We will help you locate a compatible egg source, donor egg or donor sperm as needed, depending on what gamete you froze. And lastly, for some patients who say, well, I've now gotten a clean bill of health from my doctor, I've completed my cancer therapy, but my oncologist says it would be very unsafe or risky for me to ever carry a pregnancy. This is in the terms of female patients. Well, we are certainly aware of that, and we are able to help you locate, working with different agencies, a surrogate or a carrier, or help work with you to identify someone within your own family or network who may be willing to do that for you. So these are all options and things to know. The last question that I will anticipate prior to seeing what other questions have come in is one that is sometimes the fear of your oncologist or your treating cancer doctor, which is, well, I would love for my patient to have their eggs frozen in the case of female patients, but I really, really, really do not want them having high estrogen levels, which can happen in a traditional IVF cycle. I don't want their hormone levels to go very high. And so considering that this is Breast Cancer Awareness Month, that's certainly a consideration that many of the breast cancer doctors have, which is, my patient has breast cancer. I really don't want her estrogen levels going high. I'm here to tell you that we have treatment protocols that are very mindful of that, and thus we're able to keep the patient's estrogen levels at a minimal low number, so low that sometimes it's lower than even what your normal circulating estrogen levels are when you're just walking around, even while you are being treated for your cancer. So we're very mindful of that, and we're able to avoid high estrogen while still proceeding with successfully stimulating, harvesting, i.e. retrieving and freezing eggs, or creating embryos, meaning fertilizing eggs, and then freezing those embryos. Okay, let's see what other questions we have today. So we have one question that says, how young or how old do you have to be or can be to do this? Even before a young child, 9 to 10 years old? That's a very important question, and it's a question that has a nuanced answer. So the people who have highest risk in terms of, let's speak first with women, highest risk for damage to their ovaries, etc., during chemotherapy or radiation therapy, the older you are in your reproductive years, the higher risk you are for complete loss of future fertility for two reasons. The first is, as we've talked about before, for women, as you age, the total number of eggs you have remaining decreases. So as you can imagine, let's say a woman is 38 compared to one who's 22. When she's treated with chemotherapy, the number of eggs that are there to be affected by the chemotherapy is significantly lower when she's 38 compared to when she's 22. And so she is actually, the 38-year-old is at a higher chance of having complete loss of function of her ovaries, i.e. having her eggs all be suffer demise as a result of her treatment. The other factor is, in terms of age, has to do with what, it's not really age, but what type of chemotherapy you're being treated with. So all chemotherapy regimens are not equal in terms of their likelihood to cause damage to the ovaries. As a result, in terms of your chemotherapy, not only do we simply talk to your oncologist, your cancer treatment team, or your radiation oncologist or your surgeon to know whether chemotherapy is planned, we actually ask what chemotherapy is planned. Because as part of our counseling, when I meet with the patient for a consultation, we actually talk about what the risk is to their ovarian function as a result of the specific type of chemotherapy. And that is simply to say, for some chemotherapy, the chance of complete loss of function or loss of menstruation and destruction of eggs can be high risk, intermediate risk, low risk, or negligible risk. And so it all depends on the type of chemotherapy. It depends on the dose. Sometimes not just the type, but the dose of chemotherapy planned and the duration of chemotherapy, meaning the total number of milligrams or grams of the chemotherapy that will be delivered to that patient's body. Similarly for radiation, what's the total amount of radiation that will be delivered if it's whole body radiation, or what's the total dose delivered to the pelvis if it's radiation directly to the pelvis. Can you be a young child, 9 to 10 years old? Well, the truth is, if you're prepubescent, meaning a child who hasn't entered puberty, chance of damage is diminished compared to someone who's already entered puberty. And that really has to do with the fact that if you're in puberty, your ovaries and or testes are now completely activated. They're receiving more blood flow. They're getting more delivery of anything that's circulating in your system. Your eggs also, your follicles are more activated in terms of blood flow around them. And so if chemotherapy, for example, which is delivered via the venous systems for your blood, there's a greater chance of delivery to the ovaries or testes when you're post-puberty. So short answer is the risk of damage from these treatments, chemotherapy, for example, is decreased when you're pre-pubescent. However, it can happen. And what we've noticed more, what tends to happen is, and again, it depends on the dose. Some children get chemotherapy, the total dose received isn't sufficient to cause complete loss of function of the ovary or the testis, or it doesn't cause complete loss of function in terms of them entering puberty, but their reproductive lifetime might be shorter. So for example, if average age of menopause is 51 for women in the United States, a woman who had cancer in her childhood, meaning even before age 10, and received certain chemotherapeutic regimen, as a result of having received that, although she entered puberty, had periods, was ovulating regularly, she may enter menopause in her 20s or 30s. And so, again, for patients like this, we recommend a consultation. While we may not proceed to do any form of active fertility preservation while they're still pre-pubescent, we may plan that maybe when they're 15, 16, 17, 18, 19, 20, we'll plan to freeze sperm or freeze egg just in case they were the ones who will enter early menopause as a result of having had their therapy, whether it be chemotherapy or radiation, etc. We can also offer freezing of tissue, and certainly in very young patients that may be an option, which is you freeze a portion of ovarian tissue or a portion of testicular tissue. That is something that's available, and something that is written under a special protocol, and we have to coordinate if that were the case. But honestly, it's rarely done, in part because, like I said, there's less typically chance of a child who's not yet in puberty developing full loss of function of their ovaries or testes. What they more likely suffer is that the function is there, but it's now limited, and thus they enter menopause early in their 20s or 30s if they're female, or for males, they may become azoospermic or decrease sperm production over time, as the testes can become fibrotic or not produce sperm much after a certain amount of time. Okay, other questions. How do you test fertility after cancer treatment in a male or female? In terms of a female patient, we do basic tests, might be an ultrasound to look at the ovaries to see if there are any follicles or egg houses remaining in the ovary. We would also do a blood test measuring for a particular hormone, which we had talked about in a few of our videos previously, known as anti-Müllerian hormone. We'll test for that. That's some of our basic initial testing for a female patient. For a male patient, we may start with the semen analysis. Based on the semen analysis, we may do further testing for blood tests to see whether the brain is trying to shout at the testes to make sperm and testosterone. But that would be where we would start. And then it may become more complex depending on what the findings are. That's where we would start. Okay, private message. A friend of mine 3 years ago was never given the option to save her fertility and had to undergo surgery, chemo, and now cannot have kids. Is this treatment something new? Breast cancer, when did this start? I have to say, Oncofertility and offering freezing of eggs and freezing of embryos or freezing of sperm is not very new. So it's not 3 years old. The truth is it's been available at most centers. I shouldn't say at most centers. It's been available in the United States for well over a decade. I think part of what's happened and part of what I'm trying to overcome is there hasn't been as concerted an effort to raise awareness about the availability of fertility preservation services. Certainly what has helped us in the field in the last 7 years has been that a lot of our governing societies have actually put out position statements recommending that patients who are diagnosed with cancer who are reproductive age, and typically when we say reproductive age, we're talking somewhere from age 9 to about 40, 42. And if a patient is in that age range, that they at least be counseled about the effect that their proposed therapy, whether it be chemotherapy, radiation, or surgery, may have on their chances for future pregnancy or causing a future pregnancy. And so that's been a position statement now from the American Society for Reproductive Medicine. It's a position statement from the American Society of Clinical Oncologists, which is the governing society for the cancer doctors. It's been a recommendation from a number of other medical societies. And so the recommendation is that patients at least be counseled that this can happen. Whether a patient decides to go on to freeze their eggs or sperm or to make embryos and freeze them, it's entirely up to the patient. But the recommendation now, and note I say recommendation, it's not a law. There's no law that says they have to be counseled, but the medical opinion is that the patients should be counseled on the potential effect of their therapy and be referred to someone like myself who can offer them services for freezing should they need it. Likewise, just to put it out there into the community, I, as a fertility specialist and an oncofertility specialist, do not expect that every cancer doctor will know all the details, ins and outs for counseling a patient about fertility preservation. So rather, I'm more than happy to see a patient for consultation. Seeing me doesn't mean you have to pursue your fertility preservation. Maybe you just want to know your options, and we're happy to do that as well here at Nevada Fertility Institute. Likewise, for some patients who've completed therapy, there may still be some function in your ovaries depending on what type of chemotherapy you had, how long your chemotherapy lasted, and what the dose was. And so if you've had treatment, but you're still curious to know whether or not you can freeze eggs now, freeze sperm now, or go on to get pregnant, do please consider coming in to see us. Again, we can see you then too. Okay, question. Working our way down here. Direct message. Do you work with our oncologists? Is this safe to do before chemo or radiation? Yes, I work very closely with the patient's oncologist as we plan and execute the fertility preservation strategy. This isn't done in a silo. We do not start the treatment if we don't think there's enough time. I am not an advocate for patients delaying their cancer therapy or going against their cancer doctor's advice so they can freeze eggs or sperm. The first and foremost priority in your cancer journey is treating your cancer. And so we're here to offer support. We're here to counsel on all options. If time is limited, like I said, aside from freezing eggs, freezing sperm, or freezing embryo, I will work with your cancer doctor if need be to at least perhaps decrease the likelihood of complete loss of function to your ovaries or testes if we can. And so again, the only way I can weigh in on your specific situation though would be to know what the plan is, know what the treatment goals are and your regimen. And we will talk with your doctor, we'll talk with the oncology pharmacist. We work very closely with everyone. It's really a multidisciplinary approach so that we can figure out what's the best route for you in terms of recommendations for you, but the ultimate decisions is the patient's, of course. Okay, so working our way through here. So another question that's coming in via direct messaging says, how soon can you see a patient who's been diagnosed with cancer and has a treatment plan? The short answer is, here at Nevada Fertility Institute, we take pride in stating that we would see a patient within 48 hours of contact. So if you contact us requesting an appointment, requesting a consultation, we will see you within 48 hours, at least 48 hours. Certainly, sometimes we've contacted patients and they're not quite ready to come in for the consultation, and that's fine. But our promise, and in recognition of the time-sensitive nature of oncofertility and moving on with your chemotherapy and your other cancer treatments, is we will see you within 48 hours of contact. I will even come to the hospital if I needed to do the consultation, depending on the hospital, of course. But for the most part, we will make every effort to see you and get the ball rolling for you, or at least give you counseling. Okay. Next question here. Okay. So this question asks, how many success stories do you have? You know, treatment for cancer it's a journey. And for many patients, some of them have not yet chosen to use the embryo, sperm, or egg that they've frozen, but I do have some who have. And it's quite a journey, but it's also quite uplifting and life-affirming when someone is able to come back later and say, now I'm ready, and can we proceed? With obvious reasons, a lot of our patients who are currently freezing eggs, sperm, are young, and so they're not yet prepared to start their families. But what I can tell you is, from a lot of studies that have been done out there, what we know is for patients who have been counseled about fertility preservation, the effects of their different treatment regimens, and their counsel on what that effect can have on their future chance for childbearing, when surveyed, cancer survivors, I'm thinking of one particular study where they surveyed adults who had been diagnosed with cancer and treated for cancer while children, and their overwhelming response was that the fact that someone mentioned future fertility, i.e. talked about the possibility of them starting a family later on in life, suggested to them that there was hope, suggested to them that there was a belief by their treatment team that they may survive this. And so I leave that with you, and I leave that with you as some understanding of what fertility preservation may mean. For some people, they hear us talk about oncofertility, they hear us talk about fertility preservation, and their first thought might be, but why would you want to talk about this with someone who's facing the fight of their life? Why are you talking about this with someone whose primary goal right now is surviving cancer? And the reason why our societies have come up with these recommendations of counseling patients is because we actually know what patients have said. We know what survivors have said, which is, I wish someone had counseled me. Overwhelmingly, that's something they say. Overwhelmingly, like I said, many say, the moment my team started talking to me about fertility preservation and future child raising and bearing, I started to believe I could beat this. I started to believe that survival was in the big possibility for me. The other is it's really a patient's choice, and they should be offered and fully informed. And so we really firmly believe that here at Nevada Fertility Institute, and we encourage and advise everyone to at least spread the word It may be a family member, like I said, it may be a trusted friend, it may be a coworker, it may be someone at your place of worship, maybe someone in a sports team or some other team activity that you engage in, and you may be the one to help share that this technology is now such that this is available, to share that it's affordable, to share that a consultation, at least a discussion of it, is worthwhile. And that at no point does anybody have to do it, but they ought to know everything so that in the future, if they look back, they can say, yeah, I knew about it, I knew what my options were, and I was able to make a decision one way or the other about my options. Okay, looking through here, I think we've covered all the questions for today. I thank you everyone for tuning in. Again, we in Las Vegas, I know we're a resilient bunch. You know, the events of the past week have been a challenge and continue to be a challenge. And as a community, it's very, very heartwarming to see people rising to the occasion, donating blood, donating time, donating services, and also actively just inquiring on the well-being of each other. Vegas strong. And I sincerely hope and wish that everyone is doing well. I encourage everyone here and also those in the world at large who've reached out and said hello to continue thinking of us here in Las Vegas, to come visit, share some support, and to help us advocate for meaningful change to help avoid more events like this. Thank you so much and have a good night.